Hello, my name is Gloria Sanders. I've been practicing physical therapy both clinically and academically for over 50 years. Although I have a doctorate in physical therapy, you know I didn't have a doctorate 50 years ago because there weren't any. So that's been a degree that I got later. And I'm also a retired lieutenant colonel from the Army. I want to talk about exercises that people are given post total knee arthroplasty or hip arthroplasty. We need to think about doing no harm. That's always the first thing we should think about in medicine. So when I get a patient that's been seen at a hospital and they're sent home with exercises, I edit that. I go through them and I look at which exercises should we keep, and are there some exercises they're being given that should be omitted that could do harm. The first exercise I'm going to talk about are ankle pumps. Why am I mentioning that first? Why is it the most important exercise? Well, it's the biggest muscle in the lower leg, and so it's the biggest pump of blood in the lower leg. And if blood slows down, it can make a clot. And if you make a clot in your lower leg, it goes to the right side of your heart and to your lungs. That's a pulmonary embolus, and it can kill you immediately, as dead as a doornail. So it's pretty important not to be dead. Doing ankle pumps, this is something off the internet. It shows somebody seated. That's pretty rough on the back. I would not do it this way. But what I do like about it is the person's getting resistance. I start resistance right away post total knees and total hips to this one muscle, to the calf muscle. This is the way we do it. This shows a chair that's inverted with pillows. So now the leg's up at about a 45-degree angle. So as a person is doing their resistance to their calf, which way is the blood flowing? Up the leg, not down the leg. So if there's swelling, and there's always swelling after surgery, you can't cut somebody's leg open and hack out. As a matter of fact, my nephew, who's 43, just had a total hip done. He was an NFL football player. He said they roll him into the operating room and they're giving him his spinal, and he looks over and on the tray, there's a saw, a hammer, and a chisel. He said, "This is medieval." Those were his words. So how can a patient have a total knee or a total hip surgery and not have swelling? The surgery is medieval, you know. So we elevate the legs. So in doing the ankle pumps, we're also helping the blood flow. Now, a very common exercise that's on these sheets is called quadriceps. Well, this patient's lying down. The only part of the quadriceps that crosses the hip joint is the rectus femoris, and the knee is in full extension. So the quadriceps is in the most relaxed position, shortened position, not a stretch position. So you got to contract the muscle a lot to even get movement. The only movement in a quadricep is the movement of the patella. So this can be very difficult. I mean, I've seen lots of patients. I couldn't tell if they're contracting their quadriceps or not because I couldn't really tell if the patella was moving. And it's the hardest contraction to get, not the easiest. So it's hard to tell if you're getting a good contraction. They're actually in the most lengthened position in the quadriceps, not the most shortened position. And if you bend the same knee, then you can tell if the quad is contracting. So let me show you a better way to do this. Do a short arc quadriceps exercise. Then you got movement. You can tell if the muscle is contracting because as they push the knee down against the roll under the knee, the foot moves up. So what's good about the short arc quadricep versus the quad set? You can see movement, so you know the quad is working. And this is very important. You're getting the last 15 degrees of extension, which is activated by the vastus medialis. Quadriceps, quad, 4. There are 4 parts to the quadriceps. The vastus medialis on the inside of the quad does the last 15 degrees of extension. So if a person has a stroke, if they've had surgery, it's the first part of the quadriceps to go, and it's the last part to come back. So that shows a picture of the vastus medialis oblique. It may be abbreviated VMO. That black arrow there is pointing to the vastus medialis. I don't do quadriceps. I do short arc quads. I'm strengthening the quadriceps, which is the goal, and I can tell if it's working or not. And I'm working on the VMO. Heel slides. That's a common thing that's done after hip or knee surgery. Sometimes the opposite leg is straight, sometimes it's bent, but you slide the leg. Now, you don't want to wear a hole in the heel, so sometimes we just put the foot in a pillowcase and it slides better on the bed. If you want resistance, you can start to add weights to the ankle. This is very different than a straight leg raise. It strengthens the iliopsoas muscle, but they're not lifting the weight of the whole leg. So you can accomplish, if you want to get a little more strength in the iliopsoas, you can do it without risking injury to the back. The foot is never off of the bed. Now, this shows assisting knee flexion. I don't do this one. It's hard to do seated like this person is with no support to the back. Most of the people having hip and knee surgeries are elderly, and this would be uncomfortable to their back. I do it a different way. If I'm trying to gain more knee flexion past 80 or 90 degrees, then I do it a different way, not like this. And as I've mentioned in a prior video, never, ever, no, don't do straight leg raises unless you live near me and you want to injure somebody's back so they can come to me and then I can fix their back. This shows bending the knee, gaining knee flexion, seated. Okay. This shows the foot on the floor. So the weight of the leg is supported. I occasionally do knee flexion seated, but I do it in a different way. Sometimes knees are really tight. The spacing between the femur and the tibia is, may I say, too tight. So I sit people on the side of a plinth so the weight of the leg, the foot is not touching anything. So the weight of the leg is putting distraction at the knee. And then we bend. This is showing using the opposite leg to put a force on it. There's no distraction on that knee. I might prefer to do it a different way. So, what blocks bending in the first place? There used to be a doctor in our county that would not let people leave the hospital after a total knee unless they had 90 degrees flexion. Well, by the time we got them, 2 days later, their knee looked like a football. It was so swollen. Swelling, that's the main thing. So, do you leave the swelling and then force the knee to bend, or do you try to get rid of the swelling and the knee will bend? So I advise people to use their polar packs 24/7 for the first few weeks, detach it to go to the bathroom, sit back down, pop it back in. As the knee bends, the tibia moves closer to the femur. And that's why if there's fluid in the knee, it blocks the bending. Okay, what else can block the bending? Well, they've got stitches or staples, or now they're gluing knees together. But if they have staples or stitches in the front of the knee, then that's going to block bending. So those need to come out. They come out at about 10 to 14 days. So I don't worry about flexion in the first week. Get rid of the swelling, wait till the staples are out, and then you can start working on flexion. And the other thing is adherence of the tissue to the underlying bone. Most of us have a pretty big thigh. We got plenty of excess tissue, and the bone's very well under all of that tissue. So there's no adherence of the outside scar to the bone. Different case at the kneecap. The kneecap's right under the skin. So when a person has an incision all the way across the kneecap and down the tibia, there can be scarring that tries to stick it to the bone. So we have to do massage and loosen that. We start doing it with the leg perfectly straight so the tissue is relaxed. And after the stitches and staples are out and we start bending the knee, it can seem loose with the knee in full extension, but you bend the knee 90 degrees and it's tight again. So you have to keep doing that massage and mobilizing that tissue and keeping it loose from the bone while it's being bent all the way to full flexion. This one's omitted from most post-op protocols. You do have adductor muscles and the gracilis crosses the knee joint. Well, if you've had a total knee and replacement and you're trying to strengthen things about the knee, then why are we admitting this one? And hamstring sets. My gosh, everybody knows the hamstrings cross the knee joint, bends your knee. So what, are we just going to strengthen the quadriceps and we're just going to ignore the hamstrings? Come on. It is possible to learn two muscles at the knee. I have no explanation of why people with 7 years of college and have studied all these muscles and all this stuff would omit other muscles at the knee. Young therapists don't hurt. They have never had knee pain. They don't have back problems. There's some things that I've learned from experience. One of the things I tell patients is don't walk too much in the first few weeks. You've had surgery it's like a fracture. They've taken a saw and cut through 3 bones in your body. And then we're supposed to have you walk out to the mailbox and down the street and then wonder why your knee blows up like a football. So I tell people the first couple of weeks, just walk where you have to. Go to the bathroom, get to your chair, your recliner, walk to the table to eat. But don't overdo it. I don't do any bicycle. I know most of the therapists I know a lot that I taught, like to put people on a bicycle. Well, what are you doing on a bicycle? Well, you can bill for exercise and finish drinking your coffee. You don't have to touch the patient. It's a mid-range movement, and if you do in the arc of the bicycle hit the end of that person's range, it jerks it. It can put too much force. If it's not, you're just in the mid-range, what are you doing? You're not gaining range. You're just moving a lot, and that could aggravate early on. So I don't do it, and I get patients to 130 degrees without force, without problems. So why should I do it? I like to do wall slides. I have the patient lie on their back, scoot their butt up towards the wall, put their foot on the wall, and gravity is assisting flexion. And they are in control. They can let their foot slide down the wall. When they've had enough, they can move it up a few degrees, take a rest, let it come back down. They're in control. They don't know when we're going to stop as a physical therapist pushing on their leg, so they can't relax. When they are in control, things go better. And I mentioned the scar mobilization, extremely important. That means you got to touch people, though. You got to actually put out a little bit of effort now. You got to use your own muscles. But over the patella and over the proximal tibia is very, very important. Also, doing patella mobilizations. So you put your fingers on either side of the kneecap and move it left and right and up and down and get that moving, because that will restrict bending of the leg. So those are just some little tidbits from 50 plus years of doing this job that's so wonderful. I hope it helps you, and I hope you get better at what you're doing. This is Gloria Sanders again. I want to thank you for listening to my videos, and I invite your comments. All medicine should be a discussion, and that's how we get better at what we do. We need to be able to explain why we do what we do. There's no one way to do things. So I want to hear from you. I don't know what you're being taught in PT school now. So are your professors master clinicians? Maybe, maybe not. Have they seen patients in the last 15 years? Maybe, maybe not. So I want you to tell me what you're seeing, your new graduates. Tell me what you're seeing in your clinics. Tell me what you like about this. If you disagree with something, I want to hear it. And I'll get back with you. I want a lot of comments, and if I get them, I'll do a video of just responding to comments, because I think medicine should be collaborative, and I think we need to share experiences, and I'm trying to do that with my experience, but I want to hear back from you. So subscribe, like, don't like, let me hear from you.